At the meeting this year, I spoke about the concept of intensification or de-intensification of systemic treatments in localized high-risk prostate cancer. So the concept behind this is really based on the fact that patients who have localized high-risk prostate cancer are at high risk for recurrence even after having local therapies. And that could either be androgen deprivation therapy with radiation therapy or having a radical prostatectomy. So despite those local treatments, they're still at high risk for the cancer to come back. So we know that in more advanced disease, systemic treatments, chemotherapy, hormonal agents are showing benefits, true survival benefits. So the concept is if we can move those treatments earlier, maybe we're going to be able to cure more patients. So that's what we were discussing, the different ways that those treatments are getting moved earlier. We're doing a lot of trials right now in that area, and it'll be interesting when those trials read out to give us some information as to what we do. At the same time, we have to think that we want treatments that are beneficial, but they don't cause too much toxicity. And so quality of life is important as well. So we have to balance both benefit against toxicity in this area and in this space. I also discussed the fact that in this setting, patients often will live a long, long time. And so before you get the overall survival endpoint on clinical trials, it's going to be a long time to wait, many years. And so we really need early indicators of maybe what's going on, what we call surrogates of survival. So some of these initiatives will also help, and they could be incorporated into all of our clinical trials, so we might get earlier readouts as to what drugs are being effective at what time.